Pink. Salmon. No dark red. I've returned all my patients' blood.
Close.
So
Yeah. Oh, well, see, that's, you
Close.
didn't tell me she returned it.
Well, they're done with the dialysis.
they're all done.
Makes sense.
Okay, so clamp, 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 clamp. He's got his on. I've got mine on. Okay, I'm gonna take my alcohol. And I'm gonna clean this area real good.
Scrub a dub dub.
Scrub it up, dub. Okay, then I have a nice pre-filled 10 cc syringe of saline. I'm going to unscrew this. Connect it. Flush it clear. Clamp. Get rid of this. It's on the machine. Scrub, scrub, scrub.
Does it matter which one you do first?
No. Yeah, and you'll get used to holding on to all these things. Flush 10 cc's, clamp. Okay. Actually, let's go back to which one do we eat? Arterial. You're gonna always do arterial first, and I'll get into that more when we get into the machine aspect. But get in the habit of doing arterial first. So those are flushed with 10 cc's. They're good. And then I'm gonna have little Tego caps. Okay. I don't have them here. I can't find them. So you disconnect your syringes, and they're actually called Curos. And what they are they're little caps that just pop on here, and they have a little baby sponge in there that's soaked with antiseptic. So it just kind of sits in there. Okay, so I clip on my Curos.
Does blood usually drip from the disconnected lines?
No. Okay, and then I'm going to grab a sterile, just one piece of sterile gauze is good. I'm going to open it up. Actually, these are so thin. These two. And what I'm going to do is I'm just going to lift these guys up, go underneath, and I'm just going to wrap this. Because see how these little caps, they could poke the patient.
Like a burrito.
Just wrap it like a burrito, yep, like Luke had said. Now, what I like to do is fold this and make a little, that way the next technician that opens it knows where it's at. Ooh. That's really sticky. We went from not so sticky to sticky. Okay, so it's wrapped like that. And then you can take your trucks away and they are good to go. You can help them button up their little shirts. But always encourage a patient to wear like a V-neck top or a button up, even better. That way you can get in there. Now, a couple things I want to go through. And you'll see, and I think Michaela go? Michaela can vouch for this. Alright, so I'm coming in, I undress it, I clean it real good, right? I have my sterile gauze under there. And I hook up my 10 cc syringe and I go to aspirate. And I'm getting nothing. Nothing's coming out, right? And I'm trying to get, I need to get at least 2.5 cc's, right? Because that's how long this line is. So if I don't get anything, ask the patient to take a deep breath. Because sometimes that catheter is just stuck up against the vessel wall, and he just needs to take a nice deep breath. And when he's taking a deep breath, it'll come. You'll get it. You can also ask him to cough.
So when you're pulling it and you get nothing, would you want to go again and try it again, or would you just? Oh, okay. I didn't
Yeah.
know if you could.
So it's not uncommon because you're not pushing in the air, right? It's all
Yeah.
it's suction. So if you let go, it'll snap back.
Okay.
Ask him to take a deep breath, and then it'll come. Or you can even ask him to cough. That helps. Okay. Now, if you absolutely cannot get anything, leave the syringe connected, go to the next one, pull the next one, and usually you'll get something out of the next one. Now, after you're done pulling, you just let the nurse know. I can get a pull from the arterial, but I'm not getting anything out of the venous. Then she'll tell you, she'll either come and try it herself, or she'll flush it. And when she does that, she'll give you the go-ahead to continue, okay? But if you have resistance and you can't get anything, you want to always let a nurse know so she can come in and intervene.
They usually put the blood thinners that has to sit for 45 minutes.
So, and what Michaela's talking about is, okay, so you can still run this patient, okay, so she'll come in and she'll flush it, okay? Now, if you can't get a pull on it, getting a 10 cc syringe and flushing it yourself, don't do it. Don't do it, because what if there's a clot at the tip of that catheter? You've now just pushed a clot in. That's why you let the nurse know, and if she asks you to flush it, tell her that's not within your job scope. You can say no to that, because technically only a nurse can do that, okay? So she's gonna come in, what she'll do is she'll aspirate on it, she won't get it, she can flush it. As long as, and here's the rule of thumb with the nurses, when she goes to flush, if she's not going, right, if she can flush nice and easy, that's usually a sign that everything's nice and clear, okay? But if she feels resistance, she's gonna stop, and that's what Michaela is gonna come into. Now, there's some lines that do get clogged, they get like a fibrous, it's like a fibrous plasma that gets stuck in the catheter, and the catheter won't run correctly. So you can put them on the machine, but you can't get anything higher than 100 blood flow. Well, what's the point? They're not really getting dialysis. So that's when the nurse will step in, or you don't get a pull from either. You're getting nothing.
It's a clot buster.
Yeah, she'll come in and she will, once again, you let the nurse know what your findings are. She'll come in with it's called Activase. And Activase is a medicine that the nurse will come in, she'll look at the caps and see 2.5, 3.5, she'll draw 2.5 and 3.5 out of the little syringes.
I think it's underneath there.
Oh, here we go. So she'll come with these guys, and they'll be filled with Activase, and she will push it in there, okay? And it'll be exactly as long as the catheter is on each side, and then she will let it dwell for about 45 minutes. Now, during that time, the medicine is dissolving that fibrous, kind of like that. It's like yellow. You can feel it when you're pulling back on it. And it's just busting that clot, like she said, like a clot buster. Then she comes over after 45 minutes. Not you guys can't do this. She does it. She aspirates like 3 or 4 cc's on each, and then usually you're ready to go. That's when you guys come in and you can connect and go from there. Okay.
Sometimes that doesn't even work.
Yeah, sometimes that doesn't even work either. It's just a catheter issue, and they have to go back and get a new one. Is that common? Yes, catheters literally suck. Literally, pun intended. They suck and they suck. So,
After like 5 seconds,
if
the
you-
thing would go off.
they alarm a lot. They make a lot of noise. So when you're out there and you're like, oh, what am I doing wrong? It's not you. Catheters suck. This is why we want to get them off the catheter, because they're losing dialysis. Time is precious, right? So yeah, that's why we really push the fistulas and the grafts.
The 45 minutes that is the welling, is that on top of their dialysis time, or does that go into their dialysis?
Yeah, this is a good question. Now you're going into the dialysis time, right? So the patient, usually, depending on the center and their policies, usually we have to ask the patient, okay, listen, we're now, because 45 minutes dwell time, and then the nurse has got to come back and aspirate. Well, guess what?
It's about
The
an hour and a
nurse has
half.
got 13 other patients to worry about there. She'll get there when she gets there, and that's exactly what she's going to tell you. So if you're like, can you get this? She'll be like, I'm busy, sister. You're going to have to wait. It might be another 10 minutes before she gets there. Usually they're pretty good, but they're busy. And they have a schedule they have to follow, too. So when she gets there, it could be another 55 minutes. That's when you ask the patient, we're already 55 minutes into your treatment. Do you want to get off at your regular time? And they can tell you yes, or they can tell you no. They can tell you, I got to make up my time. You got to make it up.
What do you do then for the next patient that's supposed to be sitting in that chair who's now an hour?
They're
later?
late or you move them. So, you know, the nice thing about dialysis, and I think Michaela can attest to that, when stuff like this happens, it's rare, but usually you can move the patients around because you do have patients that don't show up second and third shift. Sometimes they're in a hospital, sometimes they'll call, which is great. They'll call like at 6 and say, hey, my on time is 11, I'm not gonna be there. Boom, you got an open spot. So usually you can move that second patient, usually. So you have some wiggle room, okay? So it's not too much, but to be honest with you, the patients usually gonna say, get me the heck out of here at my normal time. And they get all worked up. Oh, now you're 45 minutes. Okay, listen, you are the patient, you call the shots. We want you to stay 4 hours. But if you can't, and a lot of times they have rides that they can't, and these transportation people, they suck. They will leave these patients. If those patients are not there at 11:15, they are gone. They have a, you know how long their waiting time is for a patient? 3 minutes. So these guys are already like, and if they bleed on the way out, they really are like, I'm gonna miss my ride. They get all upset, and I get it because they get left. So most likely this guy has transportation. He's gonna get, and then you just reassure him. You know what? You're gonna. It's okay. The good news is we busted the clot. You don't have to go to the access center because we did it here. And B, you're still gonna get out at your normal time. So let's just move forward from here. Everything's gonna be okay because they do get, and it's all good news. You just saved them a trip to the access center.
Will they have to sign off on it that they're not getting the full?
Yes.
Okay.
And they can refuse to sign that too. Yeah.
You just document it.
You just document it. Yeah.
Do you have to wear a mask when you come back in to take everything off?
Yes, anytime you're around this, touching it, near it, a mask. So really the rule of thumb I would like you guys to use when you are testing out, okay, is you're gonna come here, you're gonna take a sterile field, okay, and what I want you guys to get in the habit of is work from the top down, okay? So take this off, dump, change your gloves, get your cleaner, clean, dump, get your alcohol, clean, connect, pull, okay? Glove, dump. And then by that time, this is dry. Put a clean gauze, tape, then you're gonna work your way back down again, right? You're gonna clean, flush, and then put in heparin when you're ready to go. Okay? Any questions?
So we're able to flush a line when we're doing it, but if there's any other complications, then we're not allowed to flush the line.
We're allowed to flush a line only when we can get blood.
Okay.
Yeah, if you're pulling and you pull again and it's, then that's when you get a nurse. Because once again, she's got to assess it to make sure it's not a clot at the tip. And usually it's not. It just because if it's a clot at the tip, usually you can't even there's nothing. You can't even pull like that. Okay, so that's that, and then we encourage the patient to keep it what?
Nice and dry.
Nice and dry. Yeah, nice and dry, because really it would only just take one shower, and if that's wet, and a lot of times they'll be wet, and they'll be like, well, I just took a shower like 45 minutes ago.
Oh.
Or right before I came here, because I knew I was coming here. No, that doesn't work. It only takes a couple minutes for germs to do what they do.
So we're the only ones that clean it? Like they don't clean it themselves at home or have like a nurse come in?
No.
They can clean around it with like a sponge bath, but they just don't
Yeah.
get it.
Well, yeah, but I'm talking like deep cleaning, like the way we are cleaning it, like they don't have anybody else doing it for them.
That's correct. So on occasion, you'll get a real compliant patient that likes to do it themselves, and they'll be like, I already cleaned it, just document it, and you just go over with them how do you clean it and make sure that they have plenty of masks.
So what if
and
they lie to you and say like, oh, I just cleaned it?
yeah, for the most
Well,
part,
when
they're
you
pretty.
take it off, wouldn't you notice?
You can
Yeah.
tell. Now you get your nursing home patients when you take this off. Ooh, you got eggs in there, crumbs.
That's so nasty.
How come we just don't use like a tachoderm?
Ah, too expensive. We used to. In a perfect world, yes. And I think the skin was an issue with tegaderms too.
Yeah, you
The
feel them
skin
coming
loves, these patients love to lose their skin. It just
I mean,
comes
this is
off.
My favorite.
That we use on ostomies.
Yeah,
off. That's true.
too expensive.
Almost like,
Yeah. So for the remainder of the